Ladies and gentlemen, thank you for standing by. My name is Daphne Worrell, Marketing Manager for ODG by MCG, and I'm excited to welcome you to today's ODG Featured Partner Webinar with IntegerHealth Technologies. During this webinar, all participants will be in a listen-only mode. If you'd like to ask a question, please use the chat feature located in the lower corner of your screen. We'll save some time at the end for your questions. The webinar is being recorded, and the recording and slides will be sent to you within 1 week. We have 2 presenters today. Our first will be Jamie LaPaglia, Manager of Implementation and Clinical Education for ODG by MCG. Jamie has over 20 years of nursing experience, including over 10 years working with some of the largest carriers and TPAs in the workers' comp and disability industries. He is responsible for implementation and integration, helping to integrate and maximize the solutions provided by ODG by MCG, as well as building and managing strategic partnerships with other platform providers. Our second presenter will be William McCallum, Chief Information Officer at IntegerHealth Technologies. William has a Bachelor of Science in Electrical Engineering, followed by 35 years of experience in healthcare data analytics. Clients include healthcare systems, physician groups, hospitals, insurance companies, and workers' compensation companies. As a serial entrepreneur, Bill has created multiple companies and authored multiple healthcare patents, including merging disparate databases, data visualization, and outcomes measures. IntegerHealth integrates data from multiple client systems and utilizes ODG's APIs to automate the application of benchmarks for every claim. So we're going to send it to Jamie LaPaglia. Jamie, you can take it from here.
Thank you so much, Daphne. Okay, let me go ahead and share my screen. Hi, everybody. Thanks again for joining us today. I know everyone's really busy, so I'm really glad that everyone found some time to just see some of the great things that we're doing over here at ODG and partnering with IntegerHealth. Just want to kind of start just with a little riddle, if you will. I like to say, what is one of the most valuable assets a company has, but it's never listed on one of the company's balance sheets? And the answer is data, right? So data is so valuable, but many companies don't always appreciate or fully capitalize on the data, the value that data provides. I think our partnership with IntegerHealth really does a good job of highlighting some of the many ways that you can use data to help manage and improve outcomes for your claims organizations. Today, I'm going to just give really the star of the show today is our partnership with Integer. So we're really going to give Integer the bulk of the time today. I'm just going to do just a few-minute demonstration of ODG by MCG for those that aren't fully aware of it. Again, ODG by MCG is one of the world's leading providers in evidence-based guidelines, providing sort of 3 main domains, that being disability duration guidance, evidence-based treatment guidance, and sort of cost projections. They all sort of tie in together. And what you're looking on your screen now is the ODG by MCG platform, sort of the user interface that takes that ODG data and puts it in a way that's really easy to manage and use in your day-to-day work. But know that everything you pretty much see on the screen today is also available through integration. Such as with IntegerHealth, we take our data and we integrate it through various platforms, including various claim platforms like Guidewire's Claim Center, Claim Vantage, and some other really large ones, as well as various vendor platforms like IntegerHealth. So you'll see that the information today can be very useful. Now, in our platform, the ODG by MCG website, users can access to understand, again, disability durations based on condition, based on the ICD code, based on procedures. It's really sort of intuitive. Like I said, I won't be doing a full demo today, but just give me a brief highlight of some of the very high-level, top-value sort of points that I'm going to show you. So what I mean is this is the home page. The home page is laid out pretty simply that at the very top you can do a search. I can search for conditions, so maybe I'm doing a search for a back sprain, right? I can search by treatments. Maybe I'm going to do a knee replacement. I can search by drugs. And then I can also search by various codes. So you can see up here we have various different code sets you can add to your search criteria. So for today, I'm just going to just show you real quick maybe an ICD code, so ICD-10 code. So you can see I can also search for that. When I do a search, it's actually looking in multiple areas of the tool. I'm looking at the disability durations, medical treatments, the Tau index, which is really looking at treatments and the relationship to the outcome. The better the treatment, the better the outcome. Formulary, cost, and the new job profile piece. Towards the middle of the screen, you'll see a bit of a shortcut section, just allowing you to sort of get that information a little bit quicker. So as you saw up here, I typed in back sprain to do the search. But I could have come down here and just clicked on one of these top 15 conditions. So for instance, if I click on back sprain here, it brings me right into that back sprain on the durations page. It gives me those disability durations for a back sprain. And to make it even easier, maybe it's not one of those top 15 conditions, we've also added these top conditions here. So in addition to the 15 you see here, we have the top 100 conditions. So again, you really don't have to really even search for things. You can just simply come here. You'll see it's alphabetically ordered, and just simply click on the condition you're looking for. Maybe you have someone with a rotator cuff sprain, so I click on that one. And again, it's going to pin it to the top and show me the disability durations for someone with a rotator cuff sprain. That's really how easy it is. The other thing just real quick to show you is we also have, again, those evidence-based medical treatments. So whereas this first column here, it took me to the disability durations, this column here under medical treatments takes me to the medical treatment guidelines, right? So if I want to see the evidence-based guidance for rotator cuff repair, I simply click on that one. Again, it's going to pin it to the top, bring me to the treatment tab, and show me the guideline for evidence for rotator cuff repair. That's really how easy it is. It's really kind of clicking up, providing you high-level information up front, allowing you to sort of dig in deeper and get even more information as needed. So with that, that's the home page. There's a few other features that we can show at another time, but there's just so much that you can do with this site. But again, today we want to keep it high level to sort of give you some of the sort of more valuable, quicker tips here. So let's go back to the duration. So I'm going to go ahead and just click that back screen again. It's going to take me to the durations tab. And just to show you the durations, we have different configurability where you can see 1, 2, or all of these. In this case, I'm showing you 3 different options. We have the maximum, the average, and the best practice. We refer to as M, A, and B. The M and the A are based on actual claim data. So ODG, again, data is the key. Data is the value there. And we're taking that data from over 10 million claims, and we're going to give you the average from those claims in the form of M and the A. Now, the M is looking at all the claims. So it's 100% of the claims for, in this case, a back sprain, and we're giving you the typical return to work time frame. So the average return to work time frame for a back sprain is about 25 days. Now, the difference between the M and the A is saying, well, if the average for all the claims is 25 days, let's remove those outliers. So we're going to remove those top 5%, those ones that are sort of the outlier claims. What's the typical average for a typical back sprain claim? And that's going to be your average, your A value. So again, both these, the A and the M, are based on actual claim data. So you can use these numbers to sort of benchmark against your claim. This is a typical claim duration. So you can, again, compare yours against the benchmark, against the typical claim for the industry. Now you're probably thinking there's no way that a back sprain claim typically goes back to work in 19 or even 25 days. And you'd be correct. And the reason I say that is right now we've only told the system that it's a back sprain. We didn't tell the system who has the back sprain. Right? At the end of the day, we're not treating a back sprain. We're treating someone with a back sprain. So what we want to do is click on this refine button, and we can add some additional information here. We can add some claim level information. But before I do that, I just want to go over the last value there, which is the B value. We talked about the A and the M being based on actual claim data. Well, the B value takes out all those outliers, all those extrinsic factors, such as the social determinants of health, all those obstacles that we know impact the duration of a claim, but don't really impact the recovery from that condition. So what I mean is the physiological recovery time. So if I break my arm, the amount of time it takes for that bone to heal, or at least heal to a point where I can safely return to my pre-injury function, that's the best practice value. So that's what we want to manage towards, right? We're going to manage towards the best practice. This is our goal. This is what we want to set as an expectation for the claim. And we want to benchmark or compare against the average or the maximum, because that's the typical. Moving from the average towards the best practice. That's really the goal of managing a claim using the ODG data, taking the benchmark, moving from the benchmark towards the best practice. And again, making it claim specific by clicking on refine, adding claim level information, knowing again, if we're going to manage getting someone back to work, number one, what is the expectation? Set that goal, right? We know that we have setting a goal early in the claim, we have better outcomes. We want to share this number with the stakeholders. The second part of the 3-step process, number one, set expectations. Number two, if we're going to get someone back to work, we need to know what they do for work. So in this box here, I can enter the job title or the job class. If you know the job title, simply just enter it in that box there, and you can click on the different options that appear. If you don't know the job title, simply just click on that drop-down arrow there and pick the job class. In this case, we're using registered nurse. We'll say this nurse works in California. Let's say that the nurse is, let's say that she's, he or she is 55. Just going to quickly put a date of injury. When I enter the date of injury, it's going to give me the target return to work date. I can select a different claim type. By default, it's using all those 10 million claims. If we wanted to, we could break them out by workers' comp or non-OC, which is more like your disability claims. And then we can add those confounding factors. So this 55-year-old nurse in California also has diabetes, obesity, and hypertension. Now, if you recall, we started at 25, 19, and 10. Now we are at 120, 54, and 21. So adding that claim level information is really important, as Bill's going to show you in just a few seconds, or I should say a few minutes, when he shows you his system of how this really does make an impact on the durations and how we manage a claim. Knowing the claim variables is key to understanding and making that data valid for the claim that you're working with. As you see, we're going to manage this claim much different than we managed that claim initially, even though it's still a back sprain claim. We didn't change the condition itself, it's still a back sprain, but the durations are much different. Again, typical is about 54 days, goal is 21 days. Moving from the average towards the best practice. There's a lot more to show you on this page. The only thing I'm going to show you out today is this risk score here. The risk score looks at the average and the best practice, and it puts it into a sort of quick snapshot for you. What's the likelihood this person's going to go back to work on time versus what's the likelihood this claim is going to become one of those creeper claims, right? It's going to sneak up on you. It's going to go much longer than expected. It's going to have some obstacles or complications. The higher the risk, the more likely that's going to happen. So the risk score just looks at the average. The higher the average, the higher the risk, and the volatility, right? What's the difference between the average or the current expectation and the goal, the best practice? The wider the gap between these two, the higher the risk score. So the second step I said is define what the job is. We first do the job title. Then I can click on the job profile tab, and you'll see a description and physical demands of that job. So in this case, we have a registered nurse, so it's going to give me a job description for a registered nurse, and it's going to show me all the essential physical demands for a registered nurse, right? So we got to know what that person does for work if we're going to get them back to that job. And that job profile tab, again, all the way on the right here, will do that for you, which brings us to our third and final step, going back to that durations tab and clicking on the return to work prescription form. So the data is only as good as what you do with it. So we want to make this data actionable by communicating the expectation, the job requirements, and sending it to the stakeholders, especially the treating provider. By clicking that return to prescription form, I can now enter the claim information here, create a exportable PDF form that I can now share. And there's all these different options you can add, but for sake of time, I'm just going to quickly do this to just show you, though, at the end of the day, what I want you to see is this return to a prescription form. Again, this is a PDF document that you can now share with the stakeholders to help pursue that release to return to work. So in a nutshell, that is the ODG Durations tab. You can see just at face value, there's a lot of good information here, a lot of stuff that you can do. This is extremely helpful. We've had one client that instituted this and used that return prescription form and saw almost a 40% reduction in overall duration. So it's a very powerful tool. We talked about the job profile tab. Just real quickly, the cost, so you can benchmark and project cost based on the claim. Again, for an average, a typical claim, this is the typical cost. The closer we get them back to work towards the best practice, the lower the cost. The difference between the two is the savings, right? The tau index is based on the condition, in this case a back sprain. We're looking at what are the typical treatments for a back sprain. Are they appropriate or not? So we have green, yellow, red, and black flag. Green and yellow are appropriate, red and black are not. And then lastly is the tau index score. The higher that number, the better the outcome. Better the outcome meaning the better return to work there was. So we want to use those treatments that correspond with a good outcome. Treatment tab. These are where we house those evidence-based treatment guidelines. Because I have a back sprain pinned up here, it's going to show me those treatments that sort of correspond with a back sprain. I can click on any one of these and get the evidence-based guidance. Is it recommended? Is it not recommended? Is it conditionally recommended? What are the conditions if it's conditionally recommended? All that good stuff. Lastly, on the treatment tab, there's a treatment planning section that just gives you an overall treatment approach. So in this case, for a low back treatment plan, it gives me sort of things to look out for. If there's no radicular component, first visit, second visit, third visit, and so on. And then lastly, the extension of the treatment guidelines is the formulary. And the formulary, just like I said, it's an extension of the guidelines. It's taking all those thousands of hours of research that are done every year by ODG's editorial team, putting it in an easy-to-see table, listing it by drug class, generic name, innovator brand. Is there a generic available for that particular drug? What is the status? Is it Y or N? Y means it's safe and effective as a first-line option. N means it should go through review because it's not typically a first-line recommendation. And then sort of a typical benchmark cost. Not the actual cost, but something you can use to help sort of gauge the overall cost for that particular drug. Lastly, in the formulary is the MED calculator. This allows us to sort of understand the risk associated with the amount of opioids someone is taking. You don't have to be a clinician. All you need to do is simply just enter the dosage here for each particular drug, and it's going to tell you the corresponding risk. In this case, I'm taking 30 milligrams of Vicodin, 30 milligrams of Percocet, and overall they're at 75 MEDs a day. That lets me know they're at extreme risk, which means likely they're not going to go back to work anytime soon. So if we're not a clinician, we may want to reach out to one of our clinicians to help assign a resource. We want to do a peer review, an IME, or one of those other options that we have at our disposal to help manage this claim, because again, we know they're at high risk for adverse outcomes and likely not going to go back to work anytime soon. So again, I really just gave a very high-level overview of ODG by MCG, so I really wanted to let IntegerHealth take it away today. This is really, like I said, their time to shine. I think what they have is an amazing product. They really take the ODG data and add additional data elements and put together a product I think is extremely useful. So with that said, I'm going to go ahead and pass the sharing to Bill and let him take it away. Bill, I don't. If you might be on mute. We can't hear you. And
can you hear me now?
There we go. Thanks so much. All right, take it away, Bill.
Okay, so IntegerHealth is sort of an interesting way at looking at workers' comp. We've taken our CEO is a pediatric neurosurgeon. He's started multiple companies. He's started his own IPA at one point in time. That group now has over 600 physicians in it as an IPA and an ACO. We've worked in the Medicare Advantage space, but the real interesting thing is that we have medical context with statistical insight from our data scientists, implementation guidance from the engineers, and with a target of coming up with things that are actionable items. So we're going to start diving into that sort of real quick. We have multiple patents, and the key focus of our patents has been to make what is complex information user-friendly and actionable. As you deal with healthcare, one of the hardest things to do is come up with good data to begin with. There's always dirty data out there. There's missing data elements. And so what we try to do is use some of the processes we have to clean up the data as we go through it. And we'll use outside databases in order to do that. A simple example of that is from a zip code. We can look up the postal zip code directory and verify that the city is accurate. Then we can go over and get geocoding and look at zip codes, and we can say we want to know within 25 miles of this doctor how many of our workers' comp individuals live within that radius. So we really try to enhance that data by using some outside sources. Everything we have built is built in Microsoft products, so they're readily available industry products. But what we're going to show you today, you can do as easily as we can. And we're just going to give you some of the tools to understand exactly what we're looking at. To start out with, everybody talks about transparency. And transparency is actually very deceptive. Because to most people, transparency means what is the fee schedule of the provider. Well, the fee schedule doesn't tell you how long an individual stayed off work. And quite often you can have a provider that is low cost by himself, but he's ordering lots of tests, he's referring to a more expensive specialist, that specialist is using a surgery center that is more expensive. So just a lower cost of claim doesn't really mean that that's the better provider. So we're going to start talking and digging into that a little bit as we go. Well, to start off with, if I'm a firefighter and I have a back injury, my claim is going to cost more and it's going to take me a longer time to return to work than if I'm a programmer. And, you know, I think of myself as being pretty healthy, but if I were called upon to do the task of a firefighter, I'd have a tough time doing those. So as you use tools like ODG, or if you try to forecast the cost and the recovery time for an employee, you really need to take into account what kind of job that employee is going to return to. Now, the easy way to do that is take every one of your job titles in your company and then map them to a workload, whether that person is going to be sedentary or all the way to being a very heavy workload and job demands as they return to work. That's going to be really critical as we move forward looking at some of the information. So first thing is, what kind of job demands are going to be put on this employee as they return to work? The next thing is actually looking at pre-injury. If I have an individual that has diabetes or COPD, that person is going to take longer to recover than someone who's a marathon runner. So I need to take into account the condition of the individual having the injury. So I'm going to look at before they're injured, what kind of things existed. Did they have a heart condition? Is that going to affect their recovery time? And then I'm going to look at the post-injury conditioning to find out what kind of job that they have to return to. Both of those are pretty important. Now, the way I identify those conditions before injury is I take a look at all the diagnosis codes, not just the primary diagnosis code, and I'll find comorbid conditions in those. I also look at all the drugs that are prescribed. If someone's getting insulin, they're a diabetic. I also look at the individual procedures that are performed. You take all of those and you assign a score to each one of the patients on exactly how much of a health risk that individual has. And then we're going to use those in order to look at my providers and find out if, for example, a provider is actually treating sicker patients. It may be that a provider's cost and recovery time are longer because of the type of patients they're treating, not just because of that individual. So I'm going to want to look at both of those issues. I want to go back to ODG for just a second and show you how some of those things affect you in ODG. So I'm starting out with an individual whose job demands are sedentary, who's 18 years old, and who has a lumbar sprain. That information, ODG tells me this person I can expect to be off work for 11 days, and they have a risk score of 31. If I change just one thing, let's change just the age. So I'm going to move this person from 18-year-olds to 55. Everything else is the same. Still lumbar, still sedentary. I've changed from 11 days to 23 days off work, and I've changed my risk score from 31 to 41. Now, the first place that's important is if you're using tools like this and you're not putting in all of the right data, you will get wrong answers. So you need to put in that job function, you need to put in the age, you need to put in all the diagnosis codes. That's really important. Now, one of the things we do is we use what ODG calls an API, Application Programming Interface. We actually take every one of the client's claims and run every single one of them through automatically through this information and then get the benefit of ODG. Now I'm going to change one other thing. So I'm 55, but now I've added a compounding factor. The person has diabetes. I've now moved from 11 to 23 to 48 days. So that knowing that person had diabetes is really going to change the output of how long this person is going to be off work. My risk score is moved from 41 to 53. So the data you input is important. Now, if I rank all of my providers by their cost per claim, I get a long realm here of individuals, but what's really happening is since I'm ranking all of my providers together, and these are for a back condition, I'm comparing a neurosurgeon to a physical therapist. The physical therapist is always going to look to be less. What I really need to do is look at my providers by the kinds of services they're performing. Surgical specialists are going to cost more if they're doing operations, if they have hospital expense that may not occur with a non-surgical specialist. So I want to compare like kind of doctors. So I'm going to take the section of this graph that says non-surgical specialty, and I'm going to look at just those doctors. So now I'm ranking all of my non-surgical doctors just by their medical cost per injury. When I lay on top of that their time off work also. We get real focused on looking at the cost of a medical claim, but quite often a low-cost medical claim may result in an individual being off work for a longer period of time. It could be that I put them into therapy and I have therapy visits for 3 months, when if I had done surgery up front, it would have fixed it immediately. Well, that surgery also may have cost a lot more. So I have to look at both of those things together. And the ranking that I started out with, when I put in the cost per injury, my ranking has now changed because I have individuals that used to be very low. They're now looking like they're a lot more expensive. Then if I take that same information and I overlay on top of it that risk score we were talking about. So is the provider treating a diabetic or COPD? Are they returning somebody to work they're going back to a higher demand job? Now all of a sudden my sort order is really messed up. So if you're only looking at data from the cost of a medical claim or just from cost plus time off work, but you're not risk adjusting it, you may be looking and ranking your providers incorrectly to the point you may be trying to eliminate a doctor who in reality is saving you money, and when they go away, their high-risk patients move to someone else who isn't doing as good a job. So you really need to have that accurate set of data. The next issue is not all providers actually do a good job of entering diagnoses. If you're a radiologist, you may be entering a diagnosis for a shoulder x-ray because doctor sent the patient to you and said, do an x-ray of the shoulder. So you put down a diagnosis of a shoulder injury. But in reality, that requesting doctor was trying to rule out a shoulder. He thought it was a back problem, but you came in complaining of shoulder pain. And he wanted to rule out an injury of the shoulder and verify what really happened. So as you look at diagnoses, it ends up hospitals have professional coders that do a really good job. The surgical specialist has some medical knowledge that allows him to do a better job than a primary care doctor would. And those ancillary services for imaging and testing, those diagnoses are really not really reliable. So one of the things you want to do is you want to limit your diagnosis you're looking at to being a real physician or facility that's entering that diagnosis. Then your comorbid conditions are going to be more accurate, and you're not going to think somebody had diabetes when they don't. And the numbers that come out of a tool like ODG will be more accurate, so your forecast of your time off work and your medical expense are going to be more accurate. Some of the data you supply to things like the state, you put in a cause, a nature of injury, a body part. There are times that those are not specific enough to really get you looking at what you want to. A lower extremity could be an ankle, could be a knee, could be a hip. The cost and the time off work for those are very different. So we've done some grouping of the diagnosis codes and the procedures to get a little more specific than that. So I really am comparing like conditions from one provider to another. So as you look at providers, you get all kinds of little conversations that go on out there. And one of the conversations you get is, well, is it cheaper to do this as an outpatient surgery at a surgery center, or is it cheaper to do it inpatient? Well, in reality, that all varies. And you really can't just tell by what kind of services are performed whether you're going to get a good outcome. Well, the real question is, what's a good outcome? And part of the good outcome is how long did it take to recover? You guys have information about how long an individual is off work. In reality, that if you look at an individual and how long they're off work and when they're able to return and do the job that they should, and when it costs you the least to accomplish that, you really have the best outcome. So if you look at the entire injury, you actually can come up with a much better outcome than other people can by using that time off work as a measure of how well the patient did. Now, I talked about risk scores earlier. One of the things you run into is if you go to a physician, you say, why do your patients cost me more than all the other providers? When I send a back patient to you, I have to spend more money. The doctor's answer will always be, well, my patients are sicker. Well, unless you've taken those diagnoses and looked at those risk factors and given each patient a risk score, you don't know whether that doctor's patients are sicker or not. But sometimes there are doctors out there that get a reputation of being very good at doing something. In my area, gosh, the Dallas Cowboys do all the knee surgeries for these individuals. I want to go to that doctor because the Dallas Cowboys use him. And so all of a sudden he gets much more complex cases than other people would. He may cost me more from a medical claim cost for that individual unrisk adjusted. But he may be actually doing the best possible job for those individuals, and the risk score helps me understand that. I mentioned time off work before. We have found claims where the total medical cost was under $4,000 and the time off work was $70,000. There are some individuals who just never get returned back to work by the provider and stay off for a long period of time, getting chiropractic visits, getting physical therapy visits, and we don't need to know what a doctor has to do for the medical care if we know what the outcome is. And that is they got back to work able to do the job they're intended to do for the least expense. So you look at both of those together and you rank the provider using both of those. Now the other part of that that's really important ends up being how they refer to other people and what they use. Well, an important part of that is you can't look at this data from a billing provider. My billing provider may be a large physician network or an IPA that has 100 physicians. They have all different specialties, and you can't really compare all the different specialties together without knowing the kinds of services they perform. And each group has good and bad doctors. You may have a doctor that's really good at doing backs that is not so good at doing shoulders. And under a billing provider, they're both in the same office. You don't know that. Once you get to a rendering provider, you can find the best doctors for the conditions to be treated in that office, and you can find the worst doctors. And all you really have to do is move the patients going to the worst doctors to an average, and you'll make a very large difference. Now, one of the ways you can move those is with case managers. One of the ways you can use those is by identifying that this doctor, we've looked at all the providers and he is a really great doctor at doing backs. And you do that within your existing networks. You don't have to have any new networks. You just have to identify within the existing networks of physicians you have who does the best jobs for certain conditions and who do the worst jobs. The other issue is looking at the total injury. I'm going to use a little graphic for this. Once I have an injury, I go to my initial provider. Well, he may order tests, he may order x-rays, and how many tests and how many x-rays he orders affects the financial cost. Now, his office visit may be a flat $115, but he may be ordering tests and x-rays that are over $1,000. That provider also has a choice of which specialist he refers to. And then the specialists have their decisions of do they operate, do they do therapy, do they need more tests, do they need more x-rays. So that initial provider is a very big cost driver on downstream cost. When he refers to a specialist, does that specialist use a surgery center? Do they use inpatient? Do they use outpatient? And so if you can take all of those downstream costs and attribute percentages of those back to the initial provider and affect his referral patterns, you actually affect the overall cost. So back to our earlier discussion, if we're looking at that time off work and the return to work and the overall cost, and we can track that back to initial provider, we can impact that provider on some of his decisions and then affect our overall cost. The next thing that happens is in any given year, you're going to have claims from an injury that occurred in a prior year or an injury occurring in the current year. Injuries that occurred in prior years, all you can do really is build strategies around how to impact your claims cost or your time off work. Well, time off work, one of the things you could do is I can look at coming back to partial duty. There are all kinds of studies that say that an individual that's off work for a long period of time gets depressed. That depression affects his medical recovery and adds to cost. If they go back to work even at a limited duty, that at least affects some of that depression and affects the overall outcomes. The injuries occurring in the current year, those new injuries, you actually want to build some strategies around how do I avoid those injuries altogether. So if I know I have a whole lot of shoulder injuries, can I identify what's causing those, and is there anything that I can do with my population and training of that population to keep those injuries from occurring in the first place? And in all cases, in order to make good decisions, you have to have good data. If you're sitting there and you haven't entered anything in on the job demands, then you're expecting somebody to be back to work in 10 days and they're taking 25, and you start making decisions on these individuals who've been off work for twice as long, and you're not looking at their job demands, you're probably not making the right decisions, and you're probably not going to get the output you expect out of those. So you want to look at things that we've talked about, like those comorbid conditions, those risk factors, looking at the whole injury and the time off work, and looking at those referral patterns. It ends up that customer satisfaction surveys, they've done a lot of studies on them and figured out that they really don't tell you whether a provider is a good provider or a bad provider by whether the individual employee likes the provider or not. Customer satisfaction surveys tend to be very deceptive in nature. Healthcare tends to use a lot of things called HEDIS measures. They are measures to find out whether a provider performs certain tests that they should or not. Do they do a mammogram? Do they do prostate exams? Does the diabetic come in for an H1C test on a regular basis? It ends up that those don't really measure how well the outcome is, but you have the outcome. It's how long did it take that person to get fully recovered, back to work to do the job they're intended to do without having a lot of relapses. So for relapses, when we talk about an injury, the whole injury, including any relapses, all add together to that measure of how long somebody is off work. We talked about that earlier. So those are all the things of assigning that risk score, grouping the doctors so that I'm going to compare. I can compare across specialties. If it's a back injury, I don't care if it's a neurosurgeon or orthopedic surgeon. I want to know which one of those gives me the best outcome within this specific geography. I want to allocate the cost and the duration to the whole treatment, and I want to take those test and imaging costs and put them on the doctor that's ordering those as part of his cost. The next thing you look at is external drivers. All of a sudden I have twice as many shoulder injuries. Well, is that because I have twice as many employees or not? Is that because some regulation changed on exactly how I could do things, or I changed a policy or a procedure? Maybe I started allowing more overtime than I used to allow, and so all of a sudden my injuries went up. And so you want to look at those external drivers so you at least understand them in context of other decisions that you're making. So how do we look at, how does this become actionable items? Well, one of the municipalities we were dealing with was having, I mentioned shoulders earlier, lots of shoulder injuries. As they looked at that, one of the things they did is they hired a physical trainer and put them out in the fire department. And the physical trainer looked at the exercises the firemen were doing and figured out that the firemen were doing great exercises for bulking up and not a whole lot for eliminating individual stresses and strains that were occurring on their shoulders. So they changed their exercise routine. And then one of the firefighters came up and says, I know what part of our problem is. We've got this real heavy piece of equipment that's on the top level of the truck. And when we're lifting up to pull that piece down is when these sprains are occurring. If we restock the truck with those devices lower on the truck, we'll avoid those shoulder injuries. They went from 68 shoulder injuries in 2018 to 3 in 2019. So you can actually impact what's going to happen on your workers' comp, because now that pays off this year, next year, and the year after that by eliminating some of those shoulder sprains. The police department was having a high rate of injuries when doing certain exercises in the first week of training. And basically the police officers were not conditioned sufficiently before starting certain exercises. And so they changed some of those to later in the cycle, and they got rid of some of the injuries. So those current year injuries that you're forecasting that you're going to have, you may be able to do some things to impact those when you truly understand what kind of injuries are happening, what kind of job functions are happening too, can make a very big difference. As you look at reports, there are all kinds of different reports that you want to look at. The one that I prefer is the second one called Guided Analytics. They're reports that have little pull downs to choose what department I'm looking at, what kind of injury I'm looking at, and the rest of the report is all static with the exception of some of these little pull downs that you have to select from. You also need the ability to export data to other people. They're going to ask you for it all the time. OLAP cubes are very flexible reports, and I'll show you just pictures of what some of those look like. And depending on who the user is of the data, you can choose different reporting methodologies. There are lots of outside databases that you can tie into your existing workers' comp claims that significantly help what you're looking at. ODG is a great example. The National Provider Registry. From a provider's NPI, I can look up their specialty even if it's not loaded in the database. That helps me a lot. Once you have the data, it ends up the number of uses of that data are very, very broad. It's not just in risk management and workers' comp, but it also comes down to your stop loss, your wellness programs, your contracting, all come into play, and that data feeds into every one of those areas. One of our patents is in data visualization, and data visualization is part of that idea of taking some complex data and making it very easy. On this particular menu, if you mouse over any area of the menu, thumbnails show up on the left-hand side of what the reports end up looking like. That allows you to find a report not just by its name, but by what the report looks like because you've seen it before. Then as you start getting into information on those OLAP cubes, here what I have is the ability to do a pull down and select a year, select a logic group of what kind of claim this is. Is it a back, is it a neck or shoulder? And I can do multiples. And I can also look at the information by provider type or by a county, and then it starts kicking out the information to allow me to look and find out, is this provider doing better or worse than other providers? We produce all kinds of provider scorecards that show where a provider ranks compared to their peers, and we can do that all risk adjusted. This is a screen that's showing the total cost for an injury, the number of patients, or the average cost per patient. And if I then want to drill into this information, that guided analytics philosophy is all I have to do is put my mouse over back or over any one of the bars and click on them, and it will drill into that and give me detail by provider rather than detailed by overall company. When I look at it by provider, I have this little quadrant chart in the middle, and on the x-axis I have a high to low cost claims expense, and then I have my days off work, high to low on the vertical. So if I am in the upper right-hand quarter of that quadrant, I have providers that are both low in claims cost and low in time off work. Those are my ideal providers. Any of the providers that have a high number of days off work and high claims, I'd like to move into one of those other three quadrants, preferably the upper right-hand corner, and I'll affect my claims cost. Then this is taking each individual provider and it's telling you on that provider how they compare to the group. Were they higher on claims cost? Were they higher on absence cost or overall? And we've taken anybody who's performing below average and said, if you were performing at an average level, what kind of impact would this make on an overall cost? Now this can allow me to find out the providers that I want to use for any given condition, and so I can find my best back providers, I can find my best providers to do a shoulder. And I've selected in the upper right hand side that I'm looking for non-surgical specialists. So as you look down here at the specialty, I have physical therapists, I have chiropractors, I have rehab, all combined together. This is another way of ranking those providers where I'm taking the providers and I have the number of cases they've had, I have the average paid per injury, I have the workload adjustment, all sitting there, and then I can sort, and if I wanted to find the ones who have the lost time hours, the highest or the lowest, I can click on any one of these columns and it sorts every column, and it tells me that I had, on this first one, I had this provider ranked 34 out of 38, with 38 being the worst. And so I can see how big my size is, and by my selection I could do this by county, and I could say, oh boy, I only have 5 providers in this county, maybe I need to make it a 5-county area. Then you can expand it out. And then we can take that and we can roll it up and look at overall by elbows or by backs or by burns, how many we have in each one of the different categories, and rank those. This slide deck is available both in recorded and in printed from ODG, and so we've tried to put all the notations in here so if you want to take a look at it from that standpoint, you can. We've built lots of rules based upon the kinds of conditions, the treatments, the demographics of the individuals in order to go through and merge that time off work and the healthcare data together. Just different conditions and looking at what it looks like when you compare something on a back non-surgical, and then you do that unadjusted versus the adjusted numbers, how it sorts things back around. You can ask for an individual provider, and it actually will go all the way down to the individual person and the claim level, so you can see everything on a claim level. So if I wanted to look at Dr. Steve and all of his backs, it will give me every single back that he's had and all the detail to go along with that. And then this is the last slide. This is where we've combined everything from ODG together with the client's data. So I have a police officer, and this particular police officer, normally police officers would be a heavier workload. This one's sedentary. So we have a police officer that for some reason has a desk job. I can see all of his comorbid conditions. So he's got diabetes, he's obese, he's had a surgery before, and it's a back issue. He's had 43 days off work, but according to the comorbid calculator from ODG, and best practice here would be 112. So he's below the best practice, and we've highlighted him in green. ODG best practice for his medical and indemnity would be $40,000. What we've done from their actual is $77,000. It's higher than best practice, but it's still below the typical, so it would turn red if that was higher than the typical. Then we have a list of every diagnosis he's had, and we can look at those diagnoses and figure out exactly why we think this person has a back issue. Then we have a list of every procedure code that's been performed. And ODG gives us a number that's saying that 50% of their claims for a 97750 had 3 visits. And then I can look and find out the actual number of visits that this patient had within our system. I can look at the cost per visit from ODG, and I can look at the cost per visit that we actually paid. ODG also is supplying me with return to work guidelines. So all of that information goes back to this one individual claim, and it's run through 5 different of those APIs from ODG and automatically calculated all this out for me. And then I also have curves from CMS that tells me how often a doctor's visits should be the most complex or the least complex within office visits. And I can actually go through and identify providers that may be outliers if I'm trying to look for fraud information. And then I can look at information, again, I mentioned across specialties, whether it be orthopedic or hand surgeons or neurosurgeons and back surgeons. So that's sort of a quick little overview, hopefully giving you some information on ways that you may want to look at workers' comp and account for that time off work, account for the risk factors that are associated with the individual and the demands coming back to work, and apply that within some of the decisions that you're making and that you're looking at on how long somebody's going to be off work. And Jamie, with that, I'm going to pass it back to you and see if you have any questions or where you want to take us from here.
Sure. So go ahead and start sharing. And Daphne, I'll let you take it away. But just real quick, just so everyone knows that, again, today was more of a technical call. So you learned just some of the various ways that you can use data. I mean, and this just sort of touched on it. There's just so much you can do. And for Integer, what Bill has showed you is a lot of sort of the application of the data. But Integer actually has a user interface similar to what we showed you with ODG by MCG that allows the user to easily find that information. So today was sort of a bit of a hybrid. We kind of showed you some behind the scenes as well as some of the actual user interface. But I don't want you to feel like it's that technical. When you use the Integer's user interface, it's really super simple to use. It's point and click. I want to see this provider. I want to see this specialty. So just didn't want you to feel like that data, it's that technical when you actually use the user interface. It's really, really simple. And the last thing I promise is just the fact that, again, a lot of what they're doing is taking that data from ODG and putting it in a way that lets you compare and benchmark and better understand that claim based on the actual data. So with that, Daphne, I'll hand it over to you.
Sure. Thanks, Jamie, and thanks, Bill. That was excellent. And also, I know I received some questions about if you'll receive the recording and the slides, and yes, we will send those within a week. So although the presentation covered a lot, hopefully you can go back over it, and of course you can always contact us with the contact information on this page if you have more questions. So I'll start with some questions that seem to be for Bill. Bill, does this require me changing our provider network?
And no, what we're doing here is actually ranking the providers in your existing network, because we believe within any network or even within an office, they're both good and bad providers. And if you can identify those, then there are ways of getting people to the best providers.
Okay, thanks. And can this be used to evaluate adjusters and case managers in the same manner as providers?
So looking at nurses, case managers, adjusters, all of those are in the same data set. There's all the same risk adjusting that occurs. It's all the same workload demands that occur. So yes, you can use those not just for your provider network, but you can use it for the other parts of the network that are out there evaluating claims and directing them.
All right, and what if my state does not utilize directed care?
Okay, so it gets a lot harder if you're not allowed to help direct your care, whether it's either your own 504 network or whether you're working with your TPA and the network they have and their case managers. What you have to then do is a couple of things. One, the case managers. Secondly, you can do things like, well, back injury is my number one injury as a company. Okay, so who have you identified as being the very best back doctors out there? And without directing individual, just in your newsletter and stuff, start highlighting a couple of those doctors that you've identified as being really good doctors. And you're not directing care as much as you're suggesting who really good doctors or really good facilities are, and that can make a big difference.
All right, thanks, Bill. Jamie, here's a question for you. Is there a way to use ODG to help use data for determining if a claim is likely to have a good or a bad outcome?
Yeah, absolutely. And again, it's all about the data and how you use it. So ODG has multiple ways to do that. But I think probably the top three are going to be, again, those disability duration, setting the expectation early in the claim. Again, as Bill mentioned, there's several studies that show when you set an expectation, set that goal early, you have better outcomes. The second is the risk score. What's a back sprain claim seems pretty ambiguous. It's a back sprain, no big deal. But again, it could be a creeper. So using that risk score to see that that back sprain claim actually has a high risk based on those other comorbid conditions and all the other factors. So the risk score can really help identify those claims that may end up being a problem, if you will. And then another one is the Tau index. So while Tau is really initially developed as sort of, maybe people will hear it as the UR advisor, the UR advisor tool. It really is kind of helping identify if a treatment is appropriate or not for a given condition. But you can take it one step further. With the new addition of the Tau index score itself, we can take those average scores from each of the treatments, average them out, and I like to say if the average is more than 20, you're typically on a good approach. If it's less than 20, or certainly if it's a negative average, then you're likely on a bad approach and you probably want to intervene. So that's just some of the many ways that you can use the data or use ODG to help identify if a claim is going to be on a good track or bad track, or better said, have a good or bad outcome.
All right. Thanks, Jamie. And there's time for one quick more question. Can you integrate ODG into other systems such as claim or case management systems?
Yes, absolutely. And we actually already do with many of the largest claim systems. We do it with Guidewire's Claim Center. We do it with ClaimVantage. Many large TPAs and large carriers also, we integrate with them already, and we can continue to do that. We look for other opportunities. So, yes, we are definitely integratable. We, as you can see, integrate with Integer system. So, yeah, if you're interested in any of that, just reach out to us.
All right, great. Well, thank you so much, Jamie and Bill. This was so informative. If there are any questions that we didn't get to, we will be able to get back to you through email following the webinar, and we will also send that recording and slides. So thank you, everyone. Have a great day. Stay healthy.
Thanks. Bye, everybody.